Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 408 of our pharmacotherapy series, which majors in headache. The next clinical case reads: LDP is a 39-year-old woman with a 7-year history of migraine, without aura, and tension-type headache, who comes to the clinic requesting a refill of her Triptan. She reports an increase in the frequency of both her throbbing and dull pressure sensation headaches during the past year, and lately she has had difficulty distinguishing the two types. In the past 2 months, she has had only 5 days with no headache, and she has been much less productive in her work as a magazine editor. She has reported using 4 to 5 Triptan tablets weekly, with multiple episodes also requiring naproxen sodium, which she has purchased over the counter. She has requested 2 refills for her Triptan during the past 1.5 months. So my first question to you reads: what is the role of medication overuse in worsening symptoms, and how should this condition be managed in LDP? Medication overuse is defined as the use of triptans, ergot alkaloids, opioid analgesics, or combination analgesics on 10 or more days per month. The criterion for use of simple over-the-counter analgesics is 15 or more days per month, and often occurs in migraine and tension-type headache sufferers. The pathophysiology of medication overuse headache is multidimensional and is related to hypometabolism in neuroanatomic structures, neurochemical alterations, e.g., orexin A, or corticotropin-releasing factor, and alterations in receptor expression and neuropeptide levels, e.g., increase in CGRP. Chronic daily headaches often have features of both migraine and tension-type headaches. LDP displays many of the features of medication overuse headache. She reports an increase in the frequency of headaches to a near-daily pattern, and she is no longer able to distinguish between migrainous and tension-type headaches. Laboratory tests should be ordered to assess LDP's renal and hepatic function, and she should be questioned regarding the occurrence of gastrointestinal discomfort, acute bleeding, or a change in her stool color. In general, patients who receive abortive agents for headache treatment should be counseled to restrict their use of these agents to no more than twice per week. The design of medication withdrawal procedures can be tapered or abrupt, with a tapered withdrawal procedure recommended for opioid, barbiturate, or benzodiazepine overuse. Abrupt discontinuation can be considered suitable for triptans and non-opioid analgesics. For LDP, the discussion of a discontinuation strategy would be recommended. Such an intervention has demonstrated positive outcomes in headache reduction. Further, prophylaxis may be considered, and topiramate has demonstrated efficacy in this context. This clinical case discusses CRH, who is a 31-year-old man with a 3-year history of episodic cluster headache. He has been headache-free for the past year, but today states that the headaches are returning in their characteristic fashion. He reports abrupt onset of right-sided retroorbital pain with occasional superimposed knife-like jabs that increase in intensity for several minutes to a severe, unrelenting pain lasting about 90 minutes. The headache then gradually subsides. Associated symptoms include right-sided lacrimation, conjunctival injection, and rhinorrhea. He denies any premonition of ensuing headache or gastrointestinal upset during the attacks. Physical examination during a cluster headache shows right eyelid droop and pupillary meiosis. CRH's cluster periods characteristically last about 2 months and usually recur once or twice yearly. The first headache of the current episode awoke him from a short nap. CRH expects to suffer 1 or 2 such headaches daily because this has been the usual pattern during each cluster period. Previous cluster headaches have been symptomatically treated with aspirin and codeine 30 mg. However, CRH reports only modest relief with this treatment approach. CRH's medical history is unremarkable. He does not use tobacco but admits to occasional social drinking. So my question to you reads: what subjective and objective evidence in this case is consistent with a diagnosis of cluster headaches? CRH's gender, age of onset, quality and intensity of headache pain, periodicity of headache attacks, and associated symptoms all support the diagnosis of cluster headaches. An aura may precede a cluster headache episode. However, this effect occurs in a small percentage of patients. The episodic timeline of cluster headache is variable, extending from weeks to months, with the potential for extended remission periods. CRH's headache quality, that is severe, unrelenting pain, site, that is unilateral, evolution and resolution pattern, i.e. worsens over several minutes and resolves within 90 minutes, and periodicity of attacks, i.e. 1 or 2 headaches occurring daily for about 2 months followed by a period of remission that lasts about 1 year, are all compatible with the usual character of cluster headaches. Associated symptoms reported by CRH during headache attacks, e.g., lacrimation, rhinorrhea, conjunctival injection, and the absence of gastrointestinal or neurologic disturbances are also compatible with the diagnosis of cluster headaches. The next question reads: what abortive measures are available for symptomatic treatment of individual headaches during CRH's current cluster period? Let's briefly look at abortive therapy. The treatments of choice for abortive treatment of cluster headaches are sumatriptan by subcutaneous injection, zomitriptan nasal spray, and oxygen inhalation. Among these agents, subcutaneous sumatriptan is often preferred. Next we will look at sumatriptan. Sumatriptan 6 mg administered subcutaneously for cluster headaches reduced severity in 74% of attacks within 15 minutes compared with 26% of attacks treated with placebo. An additional injection of 6 mg does not appear to give additional headache relief. However, in patients who experience a recurrent headache after initial relief with sumatriptan, a second injection is often useful. Sumatriptan should not be used more often than twice daily during cluster bouts. A randomized, multi-center trial, assessing intranasal sumatriptan, dosed at 20 mg, compared with placebo, yielded a significantly better outcome of decreased pain response, 30 minutes following administration. Secondary outcome measures, including resolution of associated symptoms, similarly favored sumatriptan. Next we will discuss oxygen. Oxygen may be useful for patients with frequent cluster headaches who would otherwise exceed maximal dosing restrictions of sumatriptan. The mechanism of oxygen's effect is unknown, but may be related to a direct vasoconstrictive action. Clinical trial data have been mixed. In a trial of 57 patients with episodic cluster headache, 100% oxygen delivered at 12 liters per minute was deemed more effective versus placebo for achieving pain-free status at 15 minutes. A double-blind, placebo-controlled crossover study of hyperbaric oxygen treatment for cluster episodes imparted no significant beneficial effect relative to placebo. Next we will discuss zomitriptan. 2 controlled trials have established the effectiveness of intranasal zomitriptan for the acute treatment of cluster headache attacks. Cluster headache relief rates were 40% and 50% with 5 mg of zomitriptan, and 62% and 63% with 10 mg of intranasal zomitriptan in these 2 studies, respectively. And now let's consider other therapeutic interventions. The somatostatin analog, octreotide, administered by subcutaneous injection, has demonstrated superiority in efficacy relative to placebo. In addition to headache relief at 30 minutes, octreotide administration yielded improved outcomes for resolving associated cluster headache symptoms. Alternate therapeutic interventions include intranasal capsaicin, local administration of cocaine, and the local administration of lidocaine. Reasonable options for the acute treatment of CRH's acute cluster headaches include subcutaneous sumatriptan, oxygen inhalation, and intranasal zomitriptan. For many patients, oxygen is a less convenient therapy because the equipment is not easily portable and the patient must sit still during the treatment. The choice can be made on the basis of patient preference or cost. My next question to you reads: what therapeutic agents are available for headache prophylaxis during an active cluster period? Which option is most appropriate for CRH? Let's begin with prophylactic therapy. Prophylaxis should be considered in the context of chronic cluster headache episodes. An important objective for prophylactic treatment is reducing the risk of over-medication associated with acute treatment. We will now talk about verapamil. Evidence supports verapamil efficacy in cluster headache prophylaxis with daily doses in the range of 240 to 320 mg. Baseline and periodic electrocardiography should be performed for those maintained on verapamil therapy. The need for such monitoring is a function of verapamil's electrophysiologic effects on cardiac nodal tissue. And now let's look at lithium carbonate. Where primary treatment is either ineffective or contraindicated, the use of lithium as a second-line option is supported. A double-blind, crossover study found similar efficacy relative to verapamil, yet lithium was inferior to verapamil in tolerability. Lithium serum levels associated with efficacy in cluster headache prophylaxis are usually between 0.4 and 0.8 milliequivalents per liter. In addition to assessing serum levels, routine monitoring of electrolytes, hepatic, renal, and thyroid function is required. And now let's discuss suboccipital steroid injection. One high-quality randomized, controlled trial demonstrated the efficacy of suboccipital steroid injection for the prophylaxis of cluster headache in 26 patients. Injections included 12.46 mg of beta-methazone dipropionate and 5.26 mg of beta-methazone disodium phosphate mixed with 0.5 ml of 2% lidocaine. 85% of patients had relief of headache attacks within 72 hours of injection, compared with none in the placebo group. Next we will discuss topiramate. Topiramate has demonstrated efficacy for cluster headache prophylaxis. In a study of patients with prior prophylactic treatment exposure, topiramate produced favorable outcomes, inducing remission in greater than 50% of treated patients. Prompt consideration should be given to the aforementioned additional treatments if suppression of headaches during the cluster period is warranted. In general, after response to prophylactic agents such as verapamil and lithium has been established and maintained for at least 2 weeks, attempts can be made to discontinue the drug. Treatment should be reinstituted if headaches recur. With considerations toward patient ease of use and efficacy, treating CRH with verapamil or topiramate would be rational. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 409.